My name is Megan Voss, and today I'm going to be demonstrating the procedure that best demonstrates Crohn's disease. Typically, it would be a small bowel series, which is a barium contrast exam. The patient would be instructed to be NPO for 8 hours prior to the exam. This is due to the fact that food can mimic a pathology or cover it up. When the patient enters the room, I would introduce myself and verify their date of birth, last name, and any allergies. And because this is a contrast exam, I would also ask about any previous surgeries to the abdomen, any known bowel obstructions. After that, I would give the patient 2 cups of thin barium to drink. Let them sit for about 15 minutes while the barium works its way to the small bowel. After that, I would bring the patient over to the table, lie them prone. Some books say to do an AP projection, but a PA projection is better because it applies compression to the stomach, spreading out the bowels so they're not so overlapped. I have a 14 by 17 cassette in here with a left marker on the left side. I would center the patient. So the central ray is midline, just above the iliac crest, because for this projection we want to make sure to include all of the stomach. 40-inch SID. I would then measure the patient. I get 19 centimeters. Okay, so you can pause. According to our technique chart for barium exams, 19 centimeters would be 91 kVp, 10 mass, and a large focal spot. So we're going to do 91. Mass and a large focal spot. Table bucky is selected. I would then instruct my patient to take in a big deep breath, blow it out, take in one more deep breath, and this time blow it out and hold it out. At that point, I would take the exposure. After we do the first PA abdomen and the patient drinks the 2 cups, about every 30 minutes, 15 to 30 minutes depending on the department protocol, we would keep doing these projections until we see that barium has reached the large colon, the large intestine. After we have verified that barium has reached the large intestine, we would then do an RAO position. So I would like my patient 45 degrees. Cushion here, you can bend this knee. Okay. Recenter. This projection helps us visualize the ileocecal valve a little bit better, which will verify that barium has entered the large intestines. If you can't get a good view of the valve with this position, fluoro is another way that you can visualize it. They would normally use a compression paddle to help separate the bowels, to spread them out, to see the valve a little bit more. Now that I have my patient position, I'm going to go ahead and measure again. 22. Still at 40 inch SID, 14 by 17. According to the barium exposure chart, 22 centimeters would be 101 kVp. 10 mass, which we have, and large focal spot. It is still selected for table bucky and an abdomen. I would then tell the patient to take in another deep breath, blow it out, one more deep breath in, blow it out, this time hold it out, and at that point I would make the next exposure. Normally, books recommend to do an LAO, but once again, doing an RAO places the part of interest closer to the image receptor, producing a better diagnostic image.